ನನ್ನ ಹತ್ರ ಇಲ್ಲ, ಸಾರಿ. ಓಕೆ.
Ma'am, we are about to go live. Just give me one.
Yeah, please go ahead. Please go ahead. No problem. Take your time.
A very good afternoon to one and all. I am Arpita from the IGCP group. Today's topic for the webinar is practical cardiology for the practitioners. And yes, we have with us someone very eminent in this field, none other than Professor Dr. I.B. Vijayalakshmi ma'am, whom we admire so much, and it's a pleasure for me to introduce her to everyone. Though she doesn't need any introduction, but it's a courtesy. So going forward, ma'am has done MD, DM, DSC, FICC, FIAMS, FIAE, FCSI, FICP, FAMS, FISH, and also FRCP from London. She is a professor emeritus, it's a former professor HOD of pediatric cardiology at Sri Jayadeva Institute of CVS and Bengaluru Medical College and Research Institute, Bengaluru. Ma'am is the first lady cardiologist and first one to start pediatric cardiology department in Karnataka, a former professor and HOD of pediatric cardiology, as I already mentioned, in Sri Jayadeva Institute of Cardiovascular Sciences, Bangalore. She is a gold medalist in MD, a brilliant academic and non-academic career backed with 39 gold medals and 3 silver medals. She has done pioneering work in acute rheumatic fever and given Vijaya Eco criteria. So ma'am has authored Step by Step to Eco in Congenital Heart Disease, for which forward is written by Dr. Naveen C. Nanda and has edited 3 textbooks also. Ma'am has received 68 prestigious awards, including the Rajutsava Award, a Lifetime Achievement Award from Bharat Natna Abdul Kalam sir, and also the former president Srimati Pratibha Patil ma'am, 4 chief ministers, and won Best Paper Award 7 times at national and international conferences. She is the president of Indian Academy of Echocardiography. There is many more to read out, but I would now just like to hand over the session to ma'am so that she can continue. Over to you, ma'am.
Thank you so much, Arpita. Good afternoon, everybody. I'm going to talk about the just basics of cardiology. That is the practical cardiology for the practitioners. Family physician is the most important for anybody's health, for the health of patient, family, and the society. Unfortunately, nowadays, the general practitioners have become like birds of extinct because their numbers have come down. But general practitioner is a friend, philosopher, and a guide. And actually, the family doctor is the one, who has to have an comprehensive view to the cardiology so that he can guide his patients for the appropriate time and the appropriate treatment. So I'm going to speak about the cardiovascular diseases in 6 groups. One as the ischemic heart disease, which adults and most of the people are interested. Then the diabetic heart disease, because the diabetes has become very rampant. Then hypertensive heart disease, peripheral vascular diseases, rheumatic heart disease, which has come down considerably now, and also the congenital heart disease, because that is close to my heart, because I'm a pediatric cardiologist. So to start with ischemic heart disease, chest pain is the cardinal symptom. The simplest and the best method of diagnosis of any chest pain is taking a proper history. And by listening to the patient, you can comfort the patient. At the same time, you can get the confidence of the patient. And here, the history, physical examination, ECG, echocardiogram, and enzymes. These are the important investigations that have to be done. And basically, this is done to distinguish between non-cardiac chest pain, that is NCCP, from a cardiac chest pain. This is very, very important because if you take a whole gamut of chest pain, if you get 100 patients of chest pain, just 1% will be cardiac and rest of them will be non-cardiac. But for that patient, it is 100% because if it is an MI and if you miss the diagnosis, you will lose the patient. And for that family and that patient, 100% loss. And hence, you must know that nearly 40% of them, the diagnosis will be either psychological or unknown, and another 34% musculoskeletal, and then the gastrointestinal and the pulmonary, and all of them can come with the chest pain. But what is important is angina pectoris. So why cardiac pain occurs? You should understand the basic. So it is a result of the demand to supply mismatch. When the demand for oxygen increases and if the adequate supply is not there, it is called as the ischemic pain or the chest pain. And this can happen with the coronary artery disease as in atherosclerosis, or when the coronaries go into spasm, or when there is a thrombosis and obstruction to the coronary flow, or there is a dissection or coronary or arteriovenous fistula where there is a coronary steal. There is a stealing of the blood supply, and as a result, there is ischemia. So all these things can cause the chest pain and all lead to the angina. One, you can have a stable angina, variant angina, angina decubitus, that is in the lying down position, they are getting the chest pain. And last but not the least, unstable angina, which is very important to diagnose in time. Otherwise, we'll be losing the patient. The differential diagnosis of cardiac pain. One, it could be ischemic in origin, and that can happen when the patient has got an aortic stenosis. You might have seen that a young child going to the school, running to the bus, suddenly falls dead with the chest pain, and that could be due to the aortic stenosis, and it also could be due to hypertrophic obstructive cardiomyopathy, because the sudden cardiac deaths with the chest pain are common with the hypertrophic obstructive cardiomyopathy. Severe systemic hypertension can cause the chest pain. Severe pulmonary hypertension also can cause the chest pain. And aortic regurgitation, because when there is a regurgitation occurs, the diastolic pressure comes down, and most of the coronary flow is during the diastole, and with the severe aortic regurgitation, coronary flow is hampered. And then when there is a severe anemia, patient can have hypoxemia and chest pain. So a severely anemic patient can mimic like a cardiac patient with all breathlessness, easy fatigability, and chest pain. And provided you just look at the conjunctiva and the tongue, you'll make the diagnosis. And that's how these are the conditions which give rise to the cardiac chest pain. And the non-cardiac or non-ischemic chest pains are aortic dissection, pericarditis, mitral valve prolapse. So mitral valve prolapse requires only reassurance and nothing else. So here on the X-ray itself, you can diagnose the dissection of aorta, a persistent severe pain radiating to the back to the lumbar region. Remember one thing, the cardiac pain never goes below the umbilicus or below to the lower back. But in dissection, it can radiate downwards. History of hypertension will be there. Difference in the pulse in the upper limb, lower limb, or right and the left. So here you have to feel the pulse of all the four limbs and record the blood pressure in all the four limbs to make the diagnosis of dissection of aorta. The differential diagnosis of non-cardiac chest pain, invariably thoracic outlet syndrome, cervical spondylosis, costochondritis, what we call as the teat syndrome, where there is a tenderness on the costochondral junction, and herpes zoster. And in the pulmonary, you have the pulmonary embolism, pneumothorax, pneumonia, pleurisy. They all can have the pleuritic pain, which is more prominent by sneezing or coughing or taking a deep breath. So this is how you can distinguish between the cardiac and the non-cardiac. In the gastrointestinal, you can have the esophageal spasm, esophageal reflux, where the hydrochloric acid from the stomach is coming back into the esophagus, or peptic ulcer. So they also can cause the retrosternal burning, which may mimic, but here you can remember this is after the meal, and then it could be when the person is on empty stomach. Then you have the psychogenic, the anxiety, depression, cardiac psychosis, and self-gain. That means they want to get the gain the interest of the people in the house. And this is how we know the non-cardiac chest pains are divided. The angina pectoris is called when there is an ischemic pain. Location as shown in the picture, it is usually substernal, and then it radiates to the neck, and then to the left shoulder, and to the left arm, especially the ulnar region. And this is a classical radiation, and it can be radiating to the interscapular space at the back. May be associated with the sweating, palpitation, fatigue, giddiness, and pain localized to a small area over the left lateral chest is rarely an anginal. So if somebody is pointing finger and saying that pain is here, that means it is a psychogenic, and then that is not due to the angina. So angina pectoris is described as a tightness or a pressure or a burning sensation or a heaviness in the chest or aching or strangling, as if somebody is getting choked, and then there is a compression. So usually does not change with the position, unlike the respiratory causes. So induced by the exercise or emotional outbursts or a depression or overeating or exposure to the cold. And invariably it lasts only for 2 to 5 minutes. As soon as the patient takes rest, it just subsides. So anything less than 1 minute or more than 15 minutes is unlikely to be angina. And if it is continuous for days together or hours together, it is unlikely. So anything chest pain that comes on exertion and gets relieved by rest is a classical feature of angina pectoris. Now we have a term called as angina equivalent, especially among the diabetic patients who have a less pain sensitivity. They'll have breathlessness on exertion, easy fatigue, and this is due to the global ischemia. Invariably, they have a left main disease, and as a result, after meal, when they walk, they start belching, and then they feel that there is a nausea, indigestion, dizziness, sweating, choking. And you might have seen the Bollywood pictures, the person pilot is flying the plane, and then he starts belching and he becomes red and then starts sweating, and that he gets a heart attack. So this is how we know the angina equivalent is seen. The sites of secondary radiation are ulnar, aspect of the left arm, forearm, lower jaw. It never goes to the upper jaw. It's always in the lower jaw, and the teeth and the neck. And I had a patient who had gone to the dentist because of the pain in the tooth, thinking that he has got the toothache. Went for the root canal, but then it was coming on an exertion and it was getting relieved. So it turned out to be ischemia. So here, you must remember PQRST. P stands for provoked. The activity, either mental or physical one, precipitates the episode of chest pain. Q, quality of pain, either it is crushing, stabbing, burning, heaviness, or choking sensation. R stands for region and the radiation, where all it is radiating. To the left shoulder, the part of the neck, and the lower jaw, and the left arm. Then severity, rate of the pain from 1 to 10 of the scale, 1 being the least painful and 10 being the most painful. You can ask the patient. T stands for timing. Describe the duration of the pain. If it is 2 to 5 minutes, relieved by rest, it is an angina. If it is less than 1 or more than 15 minutes, it is unlikely. So what should you do? The first thing that you have to do is comfort the patient, give an aspirin, and then take an ECG. Gone are the days when they used to have a difficulty. That is the first ECG. Today, just by clicking, you can get an ECG, and even it can be on the mobile itself. It can be transferred. And this is how the ECG is taken. In the absence of pain, the patient ECG may be normal in 50% of the patients. But one thing you remember, as soon as the patient comes, the ECG may be normal. But if the history is typical, send the patient, keep the patient in observation, sedate the patient, and repeat the ECG after 1 hour for the changes, because the chest pain comes first and the ECG changes to come, it takes time, and then the blood changes. So the new horizontal or downsloping ST depressions indicate that there is a highly suggestion of the ischemia. But if the T wave is inverted or that is the upward going of the ST segment, it is an MI. So here, if the person has got angina, but there is no MI, then you have to send the patient for the treadmill exercise test. So treadmill exercise test is to screening, like how you do the screening for the tuberculosis. In the same way, to know whether it is angina or not, the cardiac or non-cardiac, we have to do the treadmill exercise test. Sometimes there can be false negative, especially in men, and 38%, and in men 22% in the women. And that's how we know it is not, if it is positive, it is significant, but if it is negative, it does not rule out the ischemia. So once you have got the treadmill exercise test and the person comes to you with the report, if the person has reached 6 to 10 meds, that means it is a functional class 1. 4 to 6 meds, it is class 2. Functional class 3 means 2 to 3. That means severe. And if the person has developed hypertension within one med, that means it is a global ischemia or the left main disease, and that patient has to undergo angiogram and surgery without delay. So this is how you have to be careful. And then if the person has reached 10 meds, that means the person is very good, and he developing MI in the next 4 years is almost 99.9% not there. So anyone having a negative test with 11 meds, it is negative. And any active person can do up to 16 meds. My own professor, pharmacology professor, who used to come on a cycle to the college, medical college, he reached 25 meds. He was so fine. And that's how we know the sedentary and active person, there is a difference. And then one has to remember A, B, C, D, E of the practical points. A stands for aspirin. As soon as you suspect MI, give aspirin. And anti-anginal, that is sublingual nitrates. Then beta blockers, and get the blood pressure checked and control the blood pressure. C for cholesterol, and take the history of cigarette smoking, because 25% of the heart attacks are because of the tobacco. Then D for diet and D for diabetic. So diabetic patients are more prone for angina and coronary artery disease. E for educate the patient, and then regular exercise, at least 5 days in a week, is important for both the cardiologists, physicians, any doctors, as well as the patients. So all of us, we have to have a regular exercise habit, and that's very important. Now, importance of medicines, it's very important that by giving aspirin, reduction of the risk is 20 to 30%. Beta blockers reduce the risk by 20 to 35%. AC inhibitors can reduce from 22 to 25%. And the statins can reduce up to 42%. And that's how we know these are the 4 important drugs in any patient with the ischemic heart disease. Now, medical therapy for angina, the aspirin is the first one. All patients with angina should continue to have 75 to 150 milligrams of aspirin every day after the meals. Identify after the discharge, or clopidogrel can be added if the patient had had an MI or the angioplasty with the stenting, the clopidogrel can be added. Next, we have the beta blockers, have potent vascular and cardiac protective effects. All patients with acute myocardial infarction, they started on admission and first line of treatment, and the treatment indefinitely it continues unless there is a contraindication for the beta blocker. The third drug is the ACE inhibitors. These agents have the potent vascular and the cardiac protective effects. All patients with acute MI started within 24 hours. First line agent for the hypertension, especially in the diabetic patient, treat indefinitely unless contraindicated. Cholesterol lowering drugs are very important. All patients with the atherosclerosis, regardless of the baseline LDL, one should start the statins. And this is important to maintain the LDL cholesterol below 100 in these patients if they have the atherosclerosis. Then comes the nitrates. These agents should be considered as a second line of treatment next to the beta blockers. And then calcium channel blockers are last ones. These agents decrease the chest pain but do not decrease the risk of cardiovascular events or the mortality. Now coming to the unstable angina, when the plate gets ruptured, the platelets try to come and clog that portion. And that's how we know when the platelet aggregation occurs, the thrombus occurs, and what is unstable angina can become an MI. And that's how, these patients, if they are diagnosed in time and treated in time, you can literally prevent the heart attack in these patients. And that's how we know the plaque rupture, disruption, acute thrombosis, vasoconstriction, all will play a role in the unstable angina. And once the MI occurs, it is like striking the bolt in the blue. Suddenly, person collapses with the severe chest pain, profuse sweating, vomiting, and in the prime of their life. Now, many people do not know what is cardiac arrest and cardiac attack or the heart attack. The heart attack is the heart supplies blood to the whole body through the aorta, and it has got the left coronary artery which branches into left anterior descending artery called as the LDA, or it is another branch is the circumflex, left circumflex artery. The right one is the right coronary artery, and this has got the RV branch and the cornel branch. And then these three together, they supply the blood to the left and the right ventricle. And what is important is the one which is the before branching, what you see is this is the left main disease. And if that left main disease has got a significant block, these are the patients who just die within minutes. And cardiac arrest is when there is a arrhythmia, ventricular fibrillation, and then there is a patient collapses. There is no heart attack, coronaries are normal, but the arrhythmia causes the death. So this is how we know we have to know the anatomy of the coronary arteries and the blocks. So nearly 25% of the deaths due to the heart attack are due to the tobacco. So tobacco is a single important preventable cause of heart attack. Now, whenever the heart attack occurs, it is like a house on fire. The earlier the firefighter comes, the damage is reduced. In the same way, earlier the patient reaches the hospital, you can prevent the damage. So within 1 hour, it is called as the golden hour. If the person comes within 1 hour, and then literally you can thrombolize the clot, and then once the streptokinase is given and the whole clot is dissolved, you can literally prevent the heart attack. And that is the golden hour. So as soon as you make the diagnosis with the chest pain, give the aspirin, sublingual, 150 or 325 milligrams, ask them to chew it and then swallow. So the chewable aspirin is the one which helps immediately, and then the streptokinase. Now, what are the other modalities of treatment? One, we have the PTCA, or we call as a angioplasty. So the blocked area, we cross it with a guide wire, and over the guide wire, this is the guide wire, over the guide wire, we pass the balloon and dilate it. This is the controlled injury. With that controlled injury, the intima and the media, they get disrupted, and the clot or the block is opened up. And then the other one is the bypass surgery. We take the veins or the arteries from the leg and the arm and the hand and the radial artery, or we can take for the lima, that is the left internal mammary artery, and bypass. So here the block is there. So you bypass it from the aorta to the distal to the block. And that is called as the bypass surgery or the CABG. So this is the open heart surgery, whereas angioplasty is the closed one. So the difference is here, the stenting is done. This is like opening the road which is blocked by reopening it. And this is leaving the congested road and building another new ring road or a bypass road is the bypass surgery. So this is how we know the two modalities of treatment are there. So when we do the angioplasty, I told you it is a controlled injury, and that there can be a collapse of the scalloping can occur. So to prevent that, we have a steel mesh, and that is called as the stent. So you have a self-expandable. That means as soon as it is removed, it opens on its own, or we have a balloon expandable stents. And now we have the drug-eluting stents, which prevent the restenosis. So here you can see that a 40 years old man, chronic smoker and diabetic, the right coronary artery is severely damaged, and then we have put a long stent to reconstruct. So this is the reconstruction of the artery with the stenting. So this is a 45 years old man who came with a severe pain, bradycardia, hypertension because there was RV infarction. And here you can see that there is a 100% occlusion of the right coronary artery. And we have opened first with the balloon, and then though it was opened up, it was not adequate. So we went ahead and put the stent. And after putting the stent, you can see that the whole coronary artery is seen. So what was 100%, this is opened. So this is the primary angioplasty, PCI, and this can literally save the person's heart and save the life. So this is how it can be done. But unfortunately, smoking is the single most important preventable cause of coronary artery disease. Unfortunately, now women also have started smoking. On one side, our Prime Minister tries to reduce the smoke by giving the HP gas, but on the other side, women are smoking. The elite one are using the e-smoking, and that contains 32 milligrams of nicotine. The chutta or the cigarette has got just 1 milligrams, whereas here this contains 32 milligrams, and that's how it is very, very dangerous. Now, smoking is associated with both aspects of atherosclerosis. It promotes the development of lesions, thus creating sites susceptible for blockage, and it also promotes the occurrence of triggering events leading to the blockage. So both are there. And one thing you remember, HDL cholesterol is a good cholesterol, and that increases by regular exercise and not smoking. And there, the blood vessels are absolutely fine. And the LDL cholesterol or HDL cholesterol or triglycerides, LDL and the triglycerides, when it is more than 200 to 400, it's very high. And there, you can see that the cholesterol deposition occurs in the subintimal layer, and then the blocks occurs. So when the blocked area, the atherosclerosis plaque ruptures, and then the platelets come and clog that area, and they cause the thrombus and the heart attack. So that's how HDL cholesterol, you have to have it at a higher 55 to 60 milligrams, and then LDL cholesterol and the triglyceride, they have to be lesser, 100 to 150. So remember, laughter is the best medicine. Anyone who's stressed can have the more heart attack, but a person who keeps laughing and it has got the best tranquilizer does not require any sedative or anything. But as on today, all over the globe, what is most important is people are getting bogged down under the stress. So we should remember there are 3 types of stress. One is the eustress. For all of us, we have to have. Like, yesterday my PPT did not open. That is all right. But today I was prepared. So that is the eustress. To do something, you have to prepare, and that is the eustress. That is natural. The stress is you don't do the work properly, you don't utilize your time, and then when the time comes, you start worrying what will happen, and that is the stress. The distress is you have got an unimaginable problem where you don't find any way to come out of it, and that time you have to say, oh God, you have to save me, or you have to help me, and that is the distress. So you should remember, eustress is required for everyone. Stress is to be avoided, and distress, though you cannot avoid, you leave it to the God. And then we have the stress junkies. As on today, most of the people, many youngsters are getting hooked to the this media, and as a result, they are wasting their time all over the night on the video games or the video thing, and then ultimately, when less than 3 hours they sleep, they can have a heart attack. Especially the cardiac arrhythmia occurs, and then they have the cardiac arrest. So sleeping for 6 to 7 hours is extremely good. And now they have shown that daytime sleeping, now more than the sleeping, even if you're dozing during the daytime, 60% reduction in the heart attack occurs. So if you are dozing in the afternoon after a meal or having a siesta, don't feel bad. That means you are going to get less heart attack. So oversleeping is not good, less sleeping is not good, but dozing in the daytime is okay. And then coming to the stress has got a bad effect all over the body. So here, the protein synthesis, the production is reduced. There will be poor digestion, increased blood clotting will be there, and under the severe stress, a person can have a heart attack. You might have seen that a young boy who had a corona infection, and he was on the way to the hospital, he died, and the father who was shifting him, he also died due to the heart attack. And that is because not of the corona, it is because of the severe stress. Losing a young boy, a son, is a severe stress. And then stress can cause increased blood pressure. And then when the blood pressure shoots up, they can have the cerebrovascular accident also. Though increase in the HCl, then the hyperacidity will be there, burning sensation will be there, body releases more sugar, stress-induced diabetes can occur, faster breathing occurs, and then the higher cholesterol. All these things can occur due to the stress. And the best method to get out of this is the Shavasana. Relax your body, close your eyes, and then just go on chanting Maha Mantra and keep your mind calm and cool. And that's it's called as the Shavasana. So Shavasana, 5 minutes in the morning before you get up from the bed or 5 minutes before you go to the bed will help you to control your stress quite a lot. And remember, whenever you do meditation, the feel-good hormones are released from the brain, and they are called as the endorphins and the neuropeptides. The endorphin is 100 times more powerful than the morphine injection that we give. And that's how we know the people who do meditation, who are siddhas, they have the pain tolerance much better than others. And this effect of meditation on the coronaries and the heart was shown scientifically by the Japanese in 1993. The Japanese people are very hardworking, and the hardworking people, the heart attack is much less. The sedentary people, lazy people, they get heart attack more. But here, suddenly 30, 35 years old young men and women, they started getting admitted to the hospital. When they did the echo and the angio, they saw that the heart was dilated, pumping capacity was just 10, 15, 20%, and then it was bloated as if the octopus is trapped into the trap. And then they called it the Takashtubo syndrome because it looked like the octopus caught in the trap. But then they evaluated everything, and then they realized that there is nothing wrong in the coronary artery. Cholesterol was mild. What was important was all of them were agitated, they were angry, they were frustrated, and they were depressed. So they realize that this is a psychosomatic one, and whatever effect is there on the brain, that is effect is happening on the coronary arteries. So this happens whenever the person gets angry or distressed or frustrated. There is a sudden surge of fight or flight hormones. Either you fight with the challenge that you have in front, or flight means run away from the challenge. And as a result, when these flight or fright hormones, that is the corticosteroids and the cortisol, are increased more than 400 times, then the coronaries go into the spasm. Once the coronaries go into spasm, there is a global ischemia, and then there is the injury, sublethal or the subclinical injury to the myocardium, and the myocardium, the pumping capacity loses, and then the heart starts pumping less, the ejection fraction becomes less, and then they saw that Indian Mahesh Yogi's transcendental meditation was practiced for just 20 minutes. Within 3 days, that is within 72 hours, the pumping capacity, which was just 10, 15, 20%, it came back to the 40, 50, 60% within 3 days. And then the whole world realized the importance of the meditation on the heart. And that's how they call it as the brain, heart, and the body axis. Whatever the effect is there on the brain due to the anger, frustration, agitation, that effect is there on the heart. And once the heart pumping capacity comes down, the blood supply to the whole body comes down, and the person starts feeling fatigued or tired, unable to do the work. And as a result, if you want to keep your heart and the mind fresh and nice, do the exercise, do the yoga, do the dhyana, do the Surya Namaskara and Chandra Namaskara. Both Surya Namaskara and Chandra Namaskara can improve your body, muscles, supple, and also your whole health. So, a kit for the healthy life is obesity, control the weight, so that obesity is the mother of not 3, 5 deadly diseases: high blood pressure, high cholesterol, heart attack. Then even Alzheimer's disease is known to occur. So limit the salt and don't take alcohol, because alcohol is 20% of the alcoholics, they get hypertension. So the hypertension in turn causes the hypertensive heart failure. So both salt and alcohol, salt has to be reduced, alcohol should be avoided. Then eat the food rich in potassium like bananas, oranges, melons, sweet lemons, tomatoes. Advise your patients to take all these nuts and the whole grain cereals, potatoes much more than they are taking now. Then you have a no smoking tobacco and minus them, and plus you start relaxing and meditate, and that will relax your mind and your heart will be better. Multiply your activity, regular walk for 30 minutes or more, 15 to 20 minutes vigorous exercise thrice in a week, and medications if prescribed by the doctor, and healthy heart and for the healthy life. This is the kit. So if you advise your patient like this, and they will be much healthy. So remember, obesity is very deadly. That too, the truncal obesity is not good. Now coming to the diabetic heart disease, diabetes is a stronger risk factor for the ischemic heart disease in women than in men. Mortality of coronary artery disease in diabetic women is 3 to 7 times much more than the non-diabetic. Diabetes is 5 to 7-fold higher in urban women, and silent ischemic attacks are more common in the diabetic, and also they can have the diabetic cardiomyopathy. And that's how we know the prognosis depends on the control of the diabetes. Diabetes mellitus, the metabolic and the infective causes of the mortality among the diabetics has certainly come down now because of the antibiotics and then the insulin and the anti-diabetic agents. But however, cardiovascular implications have gone up mainly because the cause of the morbidity and mortality have been increased, and this has been shown by the Framingham heart disease study. Clinical forms of diabetic heart disease are one, atherosclerotic coronary artery disease, two, you can have the diabetic cardiomyopathy, three, autonomic nervous system, and due to the dysfunction. All the three can be in a same patient. So causes of lack of angina is very common among the diabetics, and that's why they don't come to the doctors in time. So it is the treating physician or a clinician, if a diabetic is there, get them investigated for the coronary artery disease, because they are not going to come to you with the chest pain. By the time they come with the chest pain, it will be multiple, multi-coronary, multiple lesions. And that's how we know diabetes has to be taken very seriously. It is an independent risk factor for coronary artery disease. Nearly 55% of the diabetics, it is the more common compared to the non-diabetics. And the left main disease that I know, like a ticking of the time bomb and the causing sudden deaths, are more common among the diabetics, almost 30% more than the non-diabetics. And that's how we know it is very important to just take the profile. So the silent myocardial ischemia are more common among the diabetics, and they have the higher mortality, and the higher mortality much more so in the women. And as a result, the silent ischemic attacks must be detected by the Holter monitoring. Then coming to the hypertension in diabetic nephropathy, more diabetics are living longer and more diabetics are having the nephropathy. And hypertension has close relation with the level of albuminuria. Eventually, renal failure occurs in nearly 30 to 50% of these diabetics with the hypertension. So microalbuminuria is significant risk marker for the future mortality, and hence when the diabetic patient comes to you, see that you assess the microalbuminuria and also put them on the ACE inhibitor, and to prevent the further damage of the both kidney as well as the heart. So antihypertensives in diabetic reduce the hyperglycemic reaction to the stress, and hence diabetics on beta blockers may not experience the typical epinephrine release during the hypoglycemia. And as a result, it becomes very dangerous. You may miss the diagnosis, and hence ACE inhibitors are used commonly, and then it should be avoided if there is a renal artery stenosis. Then antihypertensive in diabetes, avoid beta blockers and diuretics. Diuretics worsen the glucose tolerance and insulin insensitivity, and also make the control of the volume expansion responsible for hypertension more difficult. And hence, diastolic blood pressure should be maintained less than 75 millimeters of mercury, and it gives the best protection towards the progression of diabetic nephropathy. Now, silent ischemia, the best thing is to do the Holter monitor, and the total ischemic burden is more in 24 hours, more than 60 minutes. It is significant, and hence get the angiogram done, either the CT angio or the coronary angio. The mortality, sudden cardiac deaths are very common in the diabetics and hypertensive, and mortality after 6 months is also, of MI is also very high. And that's how we know prevention, we have to give importance to the prevention. Now, how do you prevent? Screen the patients if they have more than one risk factor. If the parents have got the risk factor, then younger people should be very careful. So hypertension, diabetes, hypercholesterol, smoking, obesity, these are the risk factors. One should be very careful. If there is a family history of premature coronary artery death, and then it is very important. You might have remembered that Sanjeev Kumar, famous film actor, He died at the age of 45, and none of his male family members had ever survived more than 45 years. And that's how we know these people should be screened much earlier. If they have a premature death in the family, see that all other members, whether they're male or female, they have to be investigated, because the genetically transmitted diabetes, high blood pressure, high cholesterol, heart attack, no, they do not distinguish between a man or the woman. They are inherited. So if a woman may not inherit the property from parents, but she will inherit the coronary artery disease or the risk factors. So here TMT is very important. Any 2 millimeters ST depression and hypertension occurring, it may be very, very careful. So here aspirin starting lipid profile is a must in these patients. Now, coming to the congestive cardiac failure, the situation when the heart is incapable of maintaining a cardiac output adequate to accommodate metabolic requirements, and that is called as the congestive heart failure by the Braunwald. So once they go for the heart failure, it is very difficult. So now for the heart failure, we have a fantastic 4 drugs, and they 4 can be used for prevention of the heart failure. HOPE study has shown that ramipril can reduce the heart attack considerably, and that's how the AC inhibitors and the fantastic 4 for the failure, John McMurray and Milton Packer had challenged the heart failure drug, and then they called in 2020, they said that they coined it as the fantastic 4. And these drugs are one beta blocker, 2 angiotensin receptor, neprisilin, and that is called as the ARNI, and the sodium glucose transport 2 inhibitor, that is SGLT2 inhibitor, and then mineralocorticoid receptor angiotensin, that is called as MRI. So these fantastic 4 are beta blocker, ARNI, SGLT2I inhibitor, and MRA. They can literally prevent the person from going to the heart failure and later on requiring the cardiac transplant. Now, that is the salt mill in the 3000 years BC in China, and the Chinese emperor knew, the yellow emperor, that the increased salt intake can cause the thickening of the blood vessels. And in the olden days in the Europe, they used to let out the blood and they say, bravo, John, bravo. But no, letting the blood will not bring down the hypertension. Now, proper hypertensive drugs, antihypertensive drugs are very important. If there is a renovascular hypertension, do the renal artery angiogram, get the angioplasty done. We can do even the stenting. And not only that, if there is a non-functioning kidney and the hypertension is there, as in my patient, this boy had 4 drugs, and despite that, the blood pressure was 240 by 140. At the moment I put the coil in the right renal artery and the non-functioning kidney was done nephrectomy by the intervention, then the blood pressure came down to 140 by 90. So instead of going for the surgical nephrectomy, the patient can undergo the coil closure of the renal artery. The coaptation aorta is one condition where the BP is high in the upper limb and not recordable in the lower limb. So this patient was treated as a rheumatic heart disease, mitral stenosis with the atrial fibrillation in pulmonary edema. And when we had taken the patient for the balloon dilatation of the mitral stenosis, I felt the pulse, it was not there. And then I told my professor, sir, this is coaptation. He said, come on, if you can't puncture. I said, I can puncture, but this is a coaptation. So I tell, be Indian, touch the feet and feel for the dorsalis pedis or the femoral. You will never miss the diagnosis of coaptation of aorta. And in this patient, the treating physician had not recorded the blood pressure in the upper limb and lower limb, and he had failed to feel the pulse in the lower limb. And that's how he had just auscultated and said it's a mitral stenosis and then sent the patient. So remember, be Indian and be honest. So balloon aortoplasty is very, very life-saving, as in this 40 days old baby, the blood pressure was 220 by 110, and then ejection fraction was 35. And then I dilated with the balloon, ejection fraction improved, the blood pressure came down, and the patient survived. So now in the grown-up people also, we can do the opening up of the coarctation and do the stenting. The first iotoplasty that I did in a 22 years old gardener, and that patient, later on, his son has become a doctor now. And that's how we know treatment in time can save. And another condition is the iotoarthritis in our country, what is called as a non-specific iotoarthritis or Takayasu syndrome. And then here you can mid the thoracic obstruction also can be opened up with the balloon. And now we have the covered stand to avoid. And this person is not winking. In fact, you can see that there's a carotid artery block, and as a result, there is a paralysis occurring. And this can occur with the transient ischemic attacks. So any patient having transient ischemic attacks can have atherosclerosis in the other places also. They can have in the ischemia, in the limbs, and causing the gangrene of the toes or the hands, especially the diabetics with the atherosclerosis. So this patient was a 60 years old man, smoker, diabetic, hypertensive, and he had a diffuse atherosclerosis of both the common iliac arteries, and I put 2 stents on either side to save his both the limbs. And this is how, the hypertensive atherosclerotic condition can cause. Now coming on to the rheumatic fever, it says that it licks the joints and bites the heart. But today, gone are the days when we used to see the florid rheumatic heart disease. Now it has come down. And this is the child with the rheumatic fever, and her grandmother also had a rheumatic heart disease. So this is how we can see. Once upon a time, more than 30% of the bed occupancy in any ward used to be due to the rheumatic heart disease and the failure. And today we can see that we can open the whole mitral stenosis with the balloon without surgery. And then apart from that, we can do the transesophageal echocardiography and find out if there is a clot in the left atrial appendage and prevent the thromboembolism. And then we can put a device in the left atrial appendage to prevent the thromboembolism. So ultimately today, even if the pregnant woman with the mitral stenosis comes, so she had a 0.4 millimeters mitral orifice. She came with the hemoptysis, half a liter every day. And then we did the emergency. In the olden days, these women used to die during the delivery, and the ignorant people used to blame the children. And today we can say that we can cover the abdomen with the asbestos sheet and then do the balloon dilatation in the echo guidance itself. So juvenile mitral stenosis is very peculiar in our country. Less than 15 years old children, they develop the severe mitral stenosis, and then we can treat them with the balloon dilatation. I have treated more than 3,000 patients till now. Now coming to the congenital heart disease, the fetal medicine has improved so grossly. Now today, folic acid, vitamin B3 or niacin can prevent the congenital heart disease. And whenever we used to see here in the Purana that when Krishna was telling entering the Chakra Vyuha, Abhimanyu in Subhadra's womb was telling yes, but we never used to believe. But today we can make out any disease in the intrauterine life itself. Within 16 to 20 weeks of pregnancy, we can do the fetal echo, we can do the karyotyping, we can find out whether there is a AV, AV malformation is there or something is there. And then if the karyotyping shows the genetic problem, and we can say that this child is going to be Down syndrome, and we can advise the parents not to have the baby. And this is how, today, the genetic typing and then the detecting in time has increased considerably. So in the congenital heart disease, we have 7 types. One is the atrial subclinical defect. That is the simplest one, ASD. It can be closed with the device or with the surgery. Ventricular septal defect, again closed with the device or surgery. Patent ductus arteriosus or PDA, it has to be closed with the device. AP window has to be operated, and coronary AV fistula, pulmonary AV fistula, aortoventricular tunnel, they all can be treated either with the device or with the surgery. And this is Dr. Kurt Amplatz with me 30 years back when I visited his factory, and he came out with the device, the nitinol mesh with which we can close the PDA. This is how the PDA looks, and this is the device. And then we can also close the VSD, the very large VSD, close with the Amplatz device. Almost it is a huge one. And then even in a dextrocardia with the VSD, we can close it with the device. And it is so very easy now that the patient need not go for the surgery. So gone are the days when the child with the pulmonary stenosis, very critical, used to die. But today, this is a 6-day-old baby. You can see that the pulmonary valve is blocked, and so much so that there is no flow in the lungs at all. So I have opened with 1.5 millimeter, then 2.5, and then with a 6 millimeter balloon. And now this girl has become a model. Now, even a pinpoint aortic stenosis in a hydros fetalis, a literally dying child on ventilator, we can open with the balloon and then literally save the patient. So this was just a 14-hour-old baby. And in contrast, there are many in our country. This lady came with the full-term pregnancy, achondroplasia. The anesthetist was not ready to give anesthesia because she had a 176 gradient across the aortic valve. So I opened with the balloon. The aortic gradient came down, and the same evening she had the labor pain, and she underwent a cesarean section. This is how she came out with the beautiful baby after 1 week. And then I was very happy. Obstetrician was very happy, and then she never came back. And she came back after 1.5 years when she was pregnant again. So this is how our patients are. So the treating physicians, the clinicians have to be kind and advise them in proper. And here you can see that just small nick of 1 millimeter, 2 millimeter, or 3 millimeter, that's all. And that heals out because all these interventions are done through the femoral vein and the femoral artery. And later on, when the child grows, even if they wear bikini, nobody can make out. So friends, remember, as small as 2 millimeter hole in the heart can be made out by the echo. It can be diagnosed in the intrauterine life, but once they go for the Eisenmengers, nobody can do anything. This is what happened to our beautiful actress Madhubala. She had a large VST, developed Eisenmengers, and died in her 30s. And that should not happen. That is the criminal negligence on our part. So stop blaming each other and start working together. Blaming means you can't blame that the patients came late, and that is, it is our duty to educate them. And it is the duty of the cardiologists to educate the clinicians. And that's how we know we have to start working together as a team. And remember, family physician is like a captain of the ship. He sees the danger, tip of the iceberg. If he doesn't see the tip of the iceberg, and then the ship will sink. And hence, there is a Chinese proverb which says, the superior doctors prevent the disease, mediocre doctors treat the disease before it is evident, and the inferior doctors treat the full-blown disease. I'm an inferior doctor. As a professor emeritus of pediatric cardiology, I get the full-blown diseases, and that is too late. The superior doctors, like the clinicians, you can diagnose in time, suspect the disease, and then refer to the patient for the treatment in time. So friends, the best physician is the one who is able to distinguish between the possible and the impossible. And that's what the Herophilus said. And I'm sure you're much more wiser. You know what has to be done, what can be done. And as a result, you will detect in time and refer them to the proper person so that the treatment is available for all of them. Thank you very much for your kind and the patient hearing. Thank you.
Thank you, ma'am. Thank you so much. Now let us see if there are any questions from the audiences. I would request everyone, if you have any questions, please put them up and I will read them out on your behalf. Okay, so ma'am, we have received the first question.
Okay.
Ma'am, considering your extensive experience, how has echocardiography changed
Yes.
the landscape of pediatric cardiology?
Yeah.
And what advancement do you foresee in echocardiography technique in near future?
Yeah, that's a very important question. The echocardiography has not only changed for the congenital heart disease, as I told you, we can detect in the intrauterine life itself. So we can be prepared, what used to be like the stillbirth or dying after birth can be prevented if we diagnose in time. And not only that, we can make the diagnosis of rheumatic heart disease. And I have given the Vijaya's echo criteria for making the precise and the early diagnosis of carditis. And hence, these patients going for the later on valve replacement or the valve repair can be avoided if they are detected in time. So I almost went on like a waging the war and telling the zones criteria committee that the echo has to be included. And my two papers have been quoted in the 2015 where they revised. And for the first time, echo has been added as a major criteria for making the diagnosis of carditis in rheumatic fever. So whether it is a congenital heart disease or the rheumatic heart disease, echo plays a very, very important role for not only the prevention, for the treatment management and the strategy, and also during the procedure or during the surgery and the post-procedure management or the follow-up also. All that can be done with the echocardiography. So echocardiography is like a great tool. So what was like a stethoscope in the 19th century, the echocardiography is like a best tool in the 21st century. Thank you very much for asking that question.
Very beautifully cited the example, ma'am. Right. Another question on pediatric cardiology. How important is interdisciplinary collaboration in managing complex pediatric cardiac cases? And if you can just cite an example or cite a case in which you have managed such case.
It's a very, very important case. In fact, a pediatrician who was treating the patient soon after the birth. And, she never suspected because the child cried and everything was fine and, unsuspectedly. And as the duct started closing, the child became severe, cyanotic, and then the patient came back. And that time she sent the patient to me. It was a transposition of great arteries. TJ, the great arteries are transposed. So the RV blood is going into aorta, LV blood is going into the pulmonary artery. And these patients cannot survive unless the duct is kept open. And then, as soon as the diagnosis was made, they went for the surgery. And the post-surgery, the patient died. And the surgeon who operated, he put the blame on the pediatrician because they had missed the diagnosis. So she was pulled to the court for the compensation of 7 lakh rupees, what they had spent. But then, she was in tears. And then I told, this can happen because as long as the duct is open, nobody can make out unless they do the echo. Either it has to be done in the intrauterine life diagnosed or in the postnatal. And most of the time, whenever in a nursing home or a hospital, the delivery occurs, unsuspected persons will not suspect these things. And as a result, and I gave the evidence and saved that lady. And later on, she became the director of the project. And this is how we know the ignorance is not bliss. Ignorance can put you into the trouble. So best thing is to, we are one family. Don't blame each other. We have to see whether pediatrician or pediatric cardiologist or the cardiac surgeon or anesthesiologist don't blame each other. That's why I put up that slide, stop blaming each other. Work as a team. So interdisciplinary working, obstetrician, the neonatologist, and the pediatric cardiologist, and the cardiac surgeons, and the cardiac anesthetists, we have to work as a team. And then only we can be the winners by saving the precious lives.
Right, ma'am. Thank you. Thank you so much. Thank you so much for that information. And ma'am, there is another question. What are the most significant challenges that are faced in the management of congenital heart disease in children, in especially India? And how can this be addressed? Because there are many policies which we also need to abide by. So keeping that in mind.
No, there is all policies are for the betterment of the patient. No policy is going to come in the way of treating the patient properly. And the problem in our country is the antenatal echo is not done in most of the patients. So the any person, when they are doing the fetal echo for the general fetus, suppose the fetus is not growing well, or it is not with the proper age, and if they find something, they have to send the patient to the pediatric cardiologist for assessing the echo properly. Because the hydros fetalis can be detected, like the child I did, 14 hours old baby, had it been diagnosed in the intrauterine life, we could have seen that the child is immediately taken up for the intervention. In fact, in the West and even in India, they are doing the balloon dilatation in the intrauterine life itself. And that's how saving the hypoplastic left heart syndromes also. And that's how it is very important that though we think that our country is poor, we are much, much better than the other countries. The facilities are available, and now you have the Arogya, what to say, that Arogya Bharati or 5 lakhs money is given by the central government, and any patient can undergo any treatment in time. And that's how we know we are much better. Just today morning, I was discussing with the people in Greece and in Fiji. We are going for the free cardiac surgery there. So what we were in 35 years ago, now the other countries are there. So you must thank God that our country has progressed so much that we are having the world-class facilities all over the country, and you can send them anywhere for the treatment in time.
Wow. Thank you, ma'am. Thank you so much. So these were all the questions, and I guess there are no more questions now. So, ma'am,
if
thank
there
you
are
so
no
much
more questions, that means they have understood everything that I have spoken. I'm very grateful to them. Thank you.
Thank you. Thank you so much, ma'am. My deepest gratitude for you for taking your invaluable time for sharing experience and your insights. And ma'am, your dedication to improving the life of children with such heart condition is very evident. And we all know, and we are like extensively fortunate to have you in our platform. Thank you so much once again, ma'am. Thank you so much.
God bless you all.
Thank you
have
so much, ma'am.
Shubha Sanjay.
Same to you, ma'am. Thank you.
Thank you.
Thank you all for joining the session. We are concluding it for the time being. Thank you.